Okay, well, welcome to our fifth seminar in the Embedded Economist series. It's a bit of a change up this week. We're starting with Jonathan Karnon, and obviously we've got a few other things happening, so we're trying to be COVID safe here at the time being, but I think we're better that you can see us as we speak, so Jonathan will be unmasking in a second as we go forward. The topic today is the evaluation is an evaluation series on some implemented interventions, and Jonathan will speak first, and then followed by Professor Derek Chu, Head of Cardiology at this network, and has done a lot of work as an investigator, and he will talk about that as we go along. Jonathan will show you the Slido, so please help us with that. I think we had 400 odd people online, so plenty of opportunities to ask questions using Slido. I'll intervene if we need to as we go along, so thank you, Jonathan.
Thanks, Andrew, yeah, welcome back for the fifth and final of these Salin Embedded Economist seminars, and it's a pleasure to be presenting with Derek today. So just to start by acknowledging the country on which we're delivering this seminar, and pay our respects to the traditional custodians of that land, both past, present and emerging. As Andrew said, Slido is in operation again, so if you're able to go to the Slido website and enter the hashtag R525, you'll be able to submit questions, which we'll try and answer in due course. Final just acknowledgement of funders again. The Embedded Economist project funded through Health Translation SA and the MRFF and the NHMRC Partnership Centre in Health Systems Sustainability. So today, we've switched the order up in terms of I'm going to speak first. So I'm going to talk about evaluating implemented interventions and talk a bit about the kind of options for undertaking economic evaluations in practice, focusing on data and study design. So those are really the two key issues as far as I see it. I'll start with a cautionary tale, then describe data and study design options, and finish with some illustrative scenarios. And then Derek is going to present what I'd define as a gold standard case study of a clinical trial that Derek led, is recently completed. And he's also going to talk about this health data systems, health data system that he's developed with colleagues called Focus. I'm not going to define that. I'll let Derek tell you what Focus stands for. So to start my section of the talk, I just wanted to give some examples of the type of interventions that I'm talking about, and illustrate how they can go across the whole health service setting from ED. So Derek's going to talk about intervention involving high sensitivity troponin testing, but I'm also talking to the pharmacists about a pharmacist in the ED intervention that's been running here at Salin. In the inpatient setting, many of you will be aware of the Eat, Walk, and Engage intervention that's been implemented but was initially evaluated in Queensland. A recent trial that I've been involved with is evaluating wearable sensors to prevent falls in an inpatient setting. Outpatient, lots of potential evaluations around outpatient clinics. So here at Salin, multidisciplinary foot clinic is a topic of interest. Post-discharge pharmacist follow-up would also come within that category, although maybe it would also be within the outreach category, where we've got things like hospital and a nursing home and community GEM services. So just to illustrate the breadth of the types of interventions that can be evaluated in a local health service setting. So to begin at the beginning, our aims in undertaking an evaluation are basically to estimate the intervention's effects on resource use, as well as costs and outcomes. And in terms of the, I guess, general comparison scenarios that we might envisage, I guess the most common might be where we're implementing a new intervention and we want to compare the effects of that intervention to current practice, i.e. practice prior to the implementation of the intervention. But there are other scenarios where maybe we're interested in assessing the value of current practice. And so we want to compare what is currently being provided with maybe what was provided prior to a change in practice. Or we might be interested in comparing current practice across different health services. And I think that's a particular area where there's lots of potential for useful evaluation in the future. So for me, the two key evaluation issues that need to be considered and addressed are the issue of validity, ensuring that we obtain valid estimates of the effects of interventions on resource use, costs and outcomes. And the key driver of validity is ensuring that the groups that we're comparing, the intervention group and the comparator or current practice, are as similar as possible, both in terms of the demographic and clinical characteristics of patients receiving different forms of healthcare, but also in terms of the external or exogenous factors that may influence the effects of an intervention. So the most obvious one is around the season of the year in which interventions are being evaluated, and we expect differences in winter versus summer, for example. And so it's important to be aware of those types of external factors. And then the second key issue is around the scope of the evaluation. So what types of resource use, costs and outcomes data are we interested in, are going to inform a decision to be informed by the evaluation that you're undertaking. And so the linkage to the two issues that I'm going to talk about, study design and data, can be seen here. So the study design will have an important impact on the validity or the comparability of the groups being evaluated, whereas data obviously ensures or provides us with the confidence that the groups are comparable, but is also obviously key in terms of estimating outcomes. And so those are the two issues that I'm going to focus on today. But I'm going to start with, like I say, a cautionary tale. So this is an evaluation that myself and colleagues undertook a few years ago. And it was looking at a preoperative clinic that was set up to see high-risk elective surgical patients. And so the three main aims of the clinic were to advise on suitability for surgery, so potentially avoiding surgery where not indicated, or where the risks outweighed the benefits of surgery, optimizing comorbidities prior to surgery, as well as organizing post-operative plans to support recovery. But when the clinic was implemented, there wasn't a formal evaluation undertaken at implementation. And after it had been in place for 6 to 7 years, the health service thought, I wonder if this is still providing, well, I wonder if this is providing value for money, looking for potential savings. And so they requested an evaluation be undertaken. So the study design that we selected was what I would describe as a single-site retrospective cohort study. And so we were essentially comparing costs and outcomes in patients who were referred to the clinic and patients who were not referred to the clinic. And so initially you might think, well, clearly there's going to be huge differences in patients referred to the clinic and patients not referred to the clinic. But there was evidence that only a select group of surgeons were referring patients to the clinic. And so we made the decision that we would be able to control or to identify comparable groups who were referred to the clinic and not referred to the clinic through the collection of data, both administrative data, but also data extracted from patient records. In particular, data that was manually extracted from the pre-admission patient questionnaires for elective surgical patients. And so collecting that data, we then proposed to take statistical modeling, but also matching-based analysis to ensure that our patients referred and not referred to the clinic were as comparable as possible. So this is just to demonstrate that the analysis part of the process worked well. So this is a list of all of the, or not all, of the key variables that we collected for each patient. And the blue dots show that there were significant differences in those variables. But the green dots show that after our statistical adjustment for those differences, we managed to get a very comparable set of patients attending the clinic and not attending the clinic. So the results were quite surprising. So the red rectangle illustrates the set of results for which a positive effect of the clinic was observed. So for a subset of the analyses, looking at number of complications post-surgery, there was a reduction in patients attending the clinic when we used a matching-based approach for the analysis. But for all of the other outcomes, so length of stay, costs, 12-month mortality we looked at as well, and complications when using other analysis methods, the results showed that the clinic actually resulted in worse outcomes, so increased length of stay, increased costs, and increased 12-month mortality. So clearly this was a surprising and finding, and at face value is telling us that the clinic is not effective at best. At worst, it's actually reducing patient outcomes and increasing costs. But clearly, there's potential for data issues. So in terms of data, we assessed whether there was a potential to collect more or better data to provide confidence in the comparability of the patient groups. And then from a study design perspective, maybe there was an alternative study design that we could have used. So my interpretation of the results was that there probably was confounding, and that adjusting for potential confounding is really too difficult when evaluating services to which patients are referred. So even though we knew there were differences in referral patterns across surgeons, it was really the data that we could extract from the administrative and clinical systems was not sufficient to control for that confounding. So a different study design was required. So I'll come back to what those alternative study designs might be in a little bit, after just describing data options and study design options. So if we start with data, as I say, the aim of data collection is to firstly establish comparability, to provide confidence that there's comparability of patients receiving alternative interventions, but also to estimate resource use, costs, and outcomes. And referring back to the maxim of keeping things as simple as possible but no simpler, we can think about three broad data sources that can be used for evaluations. At the simplest level, we've got administrative data that can be extracted very quickly from health systems, health data systems. Clinical data involves a bit more work to extract that data, especially in the absence of electronic medical records. And then patient data is the most involved. We have to contact patients and request data from patients. So thinking about the outcomes, resource use, costs, and outcomes data, there's clearly a lot of options that we can look at in terms of the data we might want to collect in any evaluation. So we might start with resource use, so how much clinician time, what's the cost of devices and medications, extra bed days, ED presentations, hospital-acquired complications. Then we've got costs that we can assign to those resource use categories. So what's the cost of ED presentations, inpatient admissions and outpatient visits? Look at revenue minus costs to get the impact from a health service perspective. Then we're looking at patient costs. We can request consent from patients to access their Medicare data, both their MBS and PBS data. We can ask them to describe their out-of-pocket expenditure, and we can also ask them about the effects on productivity, which is essentially time off work or time off other activities, such as caring for others or volunteering. And finally, in terms of outcomes, the preferred outcome would be a patient-reported outcome measure, but we have to have systems in place to collect that data, which allows us to estimate quality-adjusted life years. And so the range of resource use costs and outcomes data that we collect should be informed by the decision that we're aiming to inform, as well as our capacity to collect these data. So the outcomes that we include may differ depending on whether we're only informing, in this case, a SALN funding decision, or whether we're looking to inform an SA Health funding decision, or if we're looking to inform policy more broadly, to inform the value of enabling the implementation of cost-effective interventions. So looking at these different data sources, we start with administrative data, and it's actually, we can extract a lot of useful information from health data systems. So in terms of baseline data that we can use to establish comparability of patient populations, there's lots of demographic data we can collect, as well as socioeconomic indices by geographical area, so by postcode. Clinical characteristics, diagnoses, external causes, even mode of arrival and previous hospital episodes in particular have been found to be very useful in establishing comparability. Outcomes data, mainly around resource use, so length of stay, time in ICU, use of mechanical ventilation, procedures. For patients undergoing rehab, there's functional independence measures, hospital-acquired complications. And post-discharge, if we can link data, we can look at readmissions, ED presentations, and mortality. Cost data is available for hospital-related episodes. So for inpatient episodes, the hospital finance department will be able to provide individual estimates of costs for every patient, both in aggregate, but also split into cost categories. And they can attach costs to ED presentations and outpatient clinics. I would just highlight that costings is not a perfect process. And talking to colleagues, Michelle in particular here, I get the impression that patient costing is a little bit like a sausage machine. You don't want to inquire too much about what goes into those patient costings and how they're estimated. But if you are interested in that process, I would highly recommend listening to Michelle talk about that. So this is a 10-minute presentation that Michelle put together for a recent data linkage conference, and it really gives you an insight into the costings process in local health services. Clinical data is the second main data source, and so this is really referring to extracting data from patient records. So we can get additional demographic data, we can get additional clinical characteristics. So in particular, we can access pathology and imaging results, as well as specific medications, and as I say, the pre-admission survey data where available. And I've put here also that as we move to electronic medical records, there is potential to routinely collect patient-reported outcomes at various points along a patient's journey. And that will not only inform our outcomes, but also provides us with additional data to establish comparability of patients at baseline. In terms of cost data, there's probably not too much additional cost information you'll get from clinical data. And then the final data source is patient data. So here we can clearly collect patient-reported outcomes to inform comparability at baseline, but also other things such as better measures of frailty, which we know is important, an important factor, especially in older patients. We can collect individual socioeconomic status data, as well as health literacy and social determinants. So there's a range of data that we can collect to ensure comparability. Outcomes, clearly, patient-reported outcomes is the preferred outcomes data. And as I've said, with cost data, there's a range of external to the hospital costs that can be collected from patients. So it really gives you the full, allows you to address the full scope of costs and outcomes if you collect patient data. But as I say, the data collection process should be kept as simple as possible, but no simpler to answer the question posed. And so, you may ask, well, what data sources are required to produce a valid evaluation? And my answer to that would be, well, it depends on your study design. And so I'm now going to talk briefly about different study designs, but essentially the two choices, as far as I see it, are around undertaking a randomized versus a non-randomized study design and a controlled versus a non-controlled study design. So the starting point obviously would be the randomized controlled trial. So we're both randomizing and controlling, which would be generally the preferred or most robust study design that we could envisage. And this is an example of a randomization process for the Eat, Walk, Engage intervention that I mentioned earlier. So rather than randomizing individuals, which would be the case when we're evaluating a new drug, for example, we'd randomize an individual to receive a control or the intervention. Here it's difficult to randomize individuals, and so we randomized wards. So there are 8 wards across 4 hospitals, and at each hospital, 1 ward was randomized to the intervention and 1 ward was randomized to the control. You can see that with 1,000 patients, that provided 80% power to demonstrate 12 fewer geriatric syndrome events per 100 admissions and a reduction of 1.35 days per acute admission. So what that is saying is that it's not powered to detect differences smaller than those outcomes, which on the face of it would be quite large intervention effects. So I guess what I'm saying is that with 8 wards, you've not got a huge amount of power to detect significant differences. So you need to take that into consideration when designing your study. The stepped wedge randomized study design is a slight alternative to that, to the traditional RCT design, where all wards, in this case, receive the intervention at some point, but different wards spend different amounts of time with the intervention in place. So the blue rectangles indicate time periods in which a ward is receiving current practice or the control, and the orange represent time periods in which the intervention is in place. So you can see Ward 4 only has 1 time period receiving the intervention, whereas Ward 3 has 4 of the 5 time periods. So the advantage of this is that you've potentially got greater comparability because all of the wards are receiving the intervention. The drawback is that the control is being received more in the early period, and the intervention is being received more in the later period. And so if there are external factors that are changing over time, then that could influence the validity of the evaluation. Moving to observational study designs, recognizing that it's often not feasible to randomize. Observational study designs can produce very extremely valid evaluation results, and this is the preferred observational study design: before and after with control, also known as a pre-post with control, or a difference in differences study. So here the blue rectangles again indicate the time periods and wards receiving the control or current practice. And so you can see we've got a time period at the beginning where both the intervention and the control wards are not receiving the intervention, and then we implement the intervention in the intervention ward but continue to observe costs and outcomes in the control ward. And so we can see differences beyond the point of introducing the intervention, but we can control for any differences between those wards that were observed in the pre-intervention period. And a nice way of analysing the data that you get from these types of studies is interrupted time series analyses. So this is an example over a 30-year time period, looking at cigarette sales in different states in the US. And in the late 1980s, in California, new cigarette taxes were introduced. So you can see prior to that point, the sales of cigarettes per person were very similar in California and their control states. So California is the aqua, and the control states is the orange. And then from the point at which the new taxes were introduced, you can see that there's a divergence in the trend. And so that's providing some really strong evidence, I would suggest, that the cigarette taxes had a positive effect in terms of reducing sales of cigarettes in California. Stepping back to an observational before and after study without control, this is quite a common study design, and clearly is not as strong as having a control in place. So here we're just comparing costs and outcomes in the period prior and the period post the introduction of the intervention. And if we refer back to this interrupted time series analysis, we could undertake an interrupted time series analysis using just the data from the intervention ward. But if you imagine this figure without the control, so without the orange series, and you look just at the aqua on its own, would you conclude that there was a difference or an effect of the cigarette taxes in California? I'd suggest potentially not, because the trend appears to be, or is certainly not. You could envisage that trend in the absence of any intervention. So you may conclude from a before and after study without control that there wasn't an effect, whereas with a control, it seems much clearer that there was an effect of the cigarette taxes. So that's really illustrating the importance or value of including a control in your observational studies. The final observational study design is a cohort study design, where we don't have the control, but we do have a control wall. We don't have a pre-period over which we can observe differences between the intervention and control wards without the intervention in place. We're just looking prospectively from the point at which the intervention was introduced. And so the issue here is that we have less confidence that the intervention and control wards are comparable. So returning to our example from before, the preoperative high-risk clinic. So as I said, the study that we undertook was a cohort study using administrative and clinical data, and the issues really were around the comparability of the clinic and non-clinic patients. So alternative options include a randomized controlled trial. Now, given that the service was already implemented at the hospital sites We couldn't randomize hospitals, but one option would have been to randomize surgeons. So instead of just leaving it to chance which surgeons referred to the clinic, we could have, if acceptable to the surgeons, randomized surgeons to enable some surgeons to refer and not provide that option to other surgeons. That would have been a potentially valid study design, and especially if we collected patient data, which would allow us to have more confidence in the comparability of patients who are being seen by different surgeons. In the absence of the feasibility of being able to randomize surgeons, we could have used a cohort study, but instead of comparing patients who were and were not referred to the clinic, we could have compared high-risk patients who were undergoing elective surgery at different hospitals, and that would give us more confidence in the comparability of patients, because high-risk patients attend every hospital, especially if you're comparing similar types of hospitals. And again, if we collected patient data, we'd have more confidence in the comparability. So that's the advantage of undertaking a prospective study, is that we could potentially collect patient data to increase our confidence in the results of the evaluation. But I think my preferred option, with hindsight, would have been a before and after study with control using administrative data. And again, the control would be high-risk populations presenting at different hospitals. And we could undertake an interrupted time series analysis to compare trends in the whole range of costs and outcomes that we're interested in at different hospitals, and see if the introduction of the high-risk clinic at our hospital site was associated with a change in trend relative to the control hospitals. But the other advantage of this type of evaluation is that if other hospitals were also introducing new approaches to managing high-risk patients, we could look at the impact of those approaches and make a comparison of different approaches, rather than just focusing on this single high-risk elective preoperative clinic. So that's how I'd do things if I was able to go back in time for the preoperative clinic. Here at Saarland, we're looking at a range of interventions for which evaluations could be undertaken, and one is the multidisciplinary outpatient foot clinic that's been in operation, I think, for around the last 18 months here at Saarland. So if we return to our PICO, the population of interest are patients, or I would define the population of interest to be patients with the capacity to benefit from attending a foot clinic. The intervention is the clinic. In terms of the comparator, we've got a couple of options. So we could look at services provided for patients with capacity to benefit prior to the introduction of the foot clinic here at Saarland, or we could look across town at services being provided in Karnon, in Naal, and the other metro health networks. In terms of outcomes, if we were just using administrative data, then we could look at things like foot-related ED presentations, which is a target of the foot clinic, trying to reduce the number of foot-related ED presentations, as well as foot-related inpatient admissions and associated length of stay. If we collected patient data, clearly we could look at the impact of the clinic on improving patients' quality of life, which is clearly a key outcome for managing foot conditions. And as with all evaluations, there are interesting issues to consider, and the issue, or one of the issues here, is around the population. So this population, as I've defined, of patients with capacity to benefit, well, you can think of three, you can split that population into three groups. So you've got patients who are referred to an outpatient foot clinic by their GP. You've got patients who are referred to foot clinics through the ED or through an inpatient setting. But then you've also got this group who've got foot needs, but they're not attending either the ED nor the foot clinic. So they're unobservable in a sense. But what you hypothesize is that following the introduction of the multi-D clinic, which incorporates an outreach component, that you're going to get more referrals from GPs. The hypothesis is you'll get fewer referrals from ED or admitted patients. And there'll also be a smaller group of patients with foot needs not attending the ED or a foot clinic. But again, you can't observe that group. So that creates problems in terms of designing a study to evaluate the cost effectiveness of the foot clinic. So just to briefly go through some of the options, one option is a before and after without control using administrative data. So as I say, the costs and outcomes we can look at would be related to ED presentations, inpatient admissions, length of stay, and we could take an interrupted time series analysis. So we're essentially looking at the impact of the clinic on the things that it's trying to prevent, which are ED presentations and inpatient episodes for foot conditions. So that would give us, a broad indication of the effectiveness and cost effectiveness of the clinic. A preferred approach would be before and after with control, again using administrative data. So it's still keeping it relatively simple, but here we're comparing ED and inpatient episodes across the different networks. And again, we can undertake an interrupted time series analysis to look at the impact of the foot clinic in Saarland and compare that to the trends observed in the other health networks. And again, if things are happening in the other health networks, we can also incorporate that in the time series analysis, and that will give us an indication of the cost effectiveness of different approaches in different health networks. So it gives us more information to inform funding decisions around managing foot conditions. If we were to go to the next stage in terms of data collection and include patient data, we could undertake a prospective study. And so in addition to our ED presentations and inpatient admissions, we could look at changes in quality of life for patients attending outpatient foot clinics. We could undertake a matched analysis of patients attending foot clinics within the different health networks to see to compare costs and outcomes across the networks. So in conclusion, I think you could do both the before and after with control using administrative data, as well as ideally a prospective study collecting patient data. Both evaluations undertaken across different networks. So a final example is around issue that I wanted to just highlight at the end here is the issue of efficiency in design and evaluation. I've kind of hinted at this value of looking at things across health services. So we're involved in a project that's looking at avoidance of readmissions in older people, and as part of that project, we've identified 3 services that are being provided across the networks, the 3 metropolitan networks here in South Australia, which were designed independently, and if they were evaluated independently. But they've all got the same objective, and to me it would make sense to try and facilitate collaboration both in the design process, but certainly in terms of the evaluation process. And so my kind of final call is for for us to think about the value of potentially developing what I've called here an South Australian intervention design and evaluation support unit, which would both support the use of economic analyses to inform the design of interventions. So what I've been talking about in previous seminars, it would enable more robust multi-site economic evaluation of interventions once implemented. But it also has potential to leverage research funds at a national level. So the MRFF is funding a lot of implementation evaluation research, and having this statewide approach would certainly strengthen our ability as a state to make successful applications for MRFF funds to undertake even more robust economic evaluation. So without MRFF funding, we may be limited to administrative data because of the costs of collecting patient data. But if we have some MRFF funding, that may facilitate collection of patient data to better inform cost effectiveness of the interventions that we're implementing. And my final slide, given this is the fifth and final seminar that I'll be presenting, is just to let you know that the Embedded Economist is formally starting early next year, that we're working with the Solon Executive to develop a work plan and prioritize what we'll be doing when we're embedded. But in general, we're essentially keen to support intervention design and evaluation in Solon, so please get in touch.
Thank you, John. No, I think we can. Let's try this. I was just sitting there, really enjoying it and realising how complicated and how biased some of the analyses that we do are. So maybe my last reflection on that was the importance for investigators to continue to work in the same area because they've learnt from their previous design, and then they understand what some of the benefits and other other aspects of it were, so that they can then ask the questions in a more sophisticated, nuanced way as we try to really understand what's going on. Can I ask you a little bit about the patient, the PROMs, the patient-reported outcomes? Because I was left thinking that in your first case there, if I was a surgeon who referred somebody to a special clinic, then the patients might feel that they've been specially selected. They're very fortunate. You're very fortunate. I'm going to send you to a special clinic, and therefore they're likely to have biased PROMs in all of that. Do you think that's a real issue? And if it is, how would we get around that in that sort of study?
Yeah, it's a good point. I'm not sure how. I'm just trying to think how you would test for that. I guess my inclination would be that probably wouldn't affect their reported outcomes because that kind of feeling that they might get from me wouldn't translate to the types of questions that are asked in patient-reported outcomes. So I don't think it would be a big issue, but yeah, it's something to kind of be aware of and consider, but difficult to test. Yeah.
The other aspect, and I guess it's not necessarily that easy, but sometimes if you had a surgeon who worked in one health system and worked in another, then we may be able to compare the health systems with the same surgeon, and we could start to work with that. So you could start to, a lot of our surgeons work in public and private, maybe if we had full access to the data, we could start to have a bit better look across some of those other aspects as well and understand how systems work when individuals are the same within that.
Yeah, potentially, although I guess potential for quite big differences between the types of patients who go private and public. But
absolutely. Yeah. Have we got any questions from Slido? Not today. Well, maybe later. But Jonathan, thank you very much. It's been great. Thanks. We're just coming to the end of the series, but I know we've had fabulous feedback. You've been a great driver on it. So thank you for that. Look forward to working with it next year and taking it another step.
Oh, thanks for the opportunity.
No,
to
fantastic.
this, yeah.
Thank you. Thanks very much. Our next speaker, if I can introduce him, is Professor Derek Chu. Derek's our head of cardiology at Salin. He's an investigator. That's investigator, interventional cardiologist. Very important. Both really important jobs, but I think they go together. We're going to hear a little bit about that. So thanks, Derek.
Andrew, thank you very much for that opportunity. I was going to pick up on some of those themes that we've had from John and from Andrew, in particular about a series of studies rather than a single one. And the second one is really about implementing research in practice and seeing whether or not we can actually get efficiencies and effectiveness out of that. Could I have my slides, please? Is it possible to change over the slides? Should we? Oh, there it is. I can do it from here. There we go. Okay, so I want to present to you a series of studies that we've been undertaking. And for us, it's very much an issue, as we all are, we're key decision makers in the system. And really, the question I have for us is how well new information adds to decision making. And for us in cardiology, the key transformative change that has happened is high sensitivity troponin. If you think about this as an issue, in our emergency departments, about 48,000 episodes of care occur that involve interpreting troponin in our state every year. About 5,000 patients have myocardial infarction. The cost of myocardial infarction is about $10,000 per admission. The cost of an admission to hospital with chest pain that ends up in an investigation is between sort of $3,000 and $5,000. And of course, the cost of missed myocardial infarction is much bigger than that. So we've been running a series of studies in this space in the emergency department. Now, another important thing has happened. High sensitivity troponin is the ability to detect troponin down to very, very low levels. And this changed in 2011. And the company introduced a high sensitivity assay. But we made a decision here in South Australia to mask the troponin level below the previous level of 30 or 29. In other words, we were able to see that result on the assay, but we didn't present it to the clinicians because we, as the clinical network, were very concerned that this might actually lead to an increase in cardiac investigations and not necessarily an improvement in clinical outcomes. So that enables us to actually run unmasked or blinded and non-blinded randomized trials. So this is the first of our randomized trials. It was run in around 2016, and you can see that, in fact, there was no overall improvement in care or outcome associated with giving clinicians in emergency departments the high sensitivity troponin result. At that time, this was the first randomized trial comparing high sensitivity versus standard reporting in real-world practice. Despite this, there was a lot of cries, particularly from other centres in South Australia, that we really needed to get access to high sensitivity troponin because the rest of the world was certainly doing this. But nevertheless, there was further literature that suggested that potentially using a high sensitivity troponin assay will enable us to differentiate patients more precisely and discharge more patients, and do that in 1 hour rather than the usual 3 and 6 hours. So we ran a randomized trial of this. Again, think of the difficulty of doing that. We were in the acute space, in the emergency department, randomizing patients to a 3-hour versus a 1-hour protocol. And the poor clinicians had to keep up, if you like. On one set of patients, they were following a single hour protocol. The other, they were running a 3-hour protocol. The only way that we could actually maintain the blind, if you like, is to only reveal the high sensitivity troponin results amongst those patients who were randomized to the 1-hour arm. Of course, you will recognize already that patients presenting with a troponin above 30 would be effectively unmasked to both study arms, and that's important. So in fact, we showed that we could shorten the length of stay in the emergency department. This is the time between troponin testing. It did not increase the diagnosis of myocardial infarction. It didn't really increase the diagnosis of any of the other diagnostic classifications either. What is important is that it reduced functional testing. So in other words, we actually gave clinicians the confidence to reduce their functional testing, and I'll pick up on that in a second. But in the converse, it also increased the rate of angiography. And again, this is a randomized study where the clinicians were effectively masked or blinded to the high sensitivity result in the control arm. And so it allows us to detect relatively small differences in practice and potentially outcome. And this is the 30-day outcome of death and recurrent myocardial infarction. You can see that there's no difference. People discharged earlier off the 1-hour protocol had no difference in 30-day death or recurrent myocardial infarction, so that was obviously very reassuring. But of a small degree of concern, cardiovascular readmission by 30 days was slightly more, was slightly elevated, and we really weren't clear what the cause of this was. This is, again, the 30-day endpoints amongst those with a low-level troponin elevation less than 29, again highlighting the issue that these are the populations where the results were either masked or unmasked, so the true test in the trial. And you can see that there's a greater rate of patients presenting with recurrent chest pain, but not much difference in other clinical events. Although the point estimate for those receiving the high sensitivity troponin result was slightly higher. What we did see was in fact a statistically significant increase in myocardial injury. So that's us potentially causing harm in these patients. In patients, there was a slightly higher rate of patients coming in with spontaneous myocardial infarction as well as revascularization-induced myocardial infarction and also myocardial injury. So this is the first time that anybody outside our research group has seen the 12-month results from this trial. And I would say that we were a little surprised, but again, we have a randomized trial that has put this in front of us. But we can actually see that there is an actual increase in the rate of death and recurrent myocardial infarction by 12 months with the implementation of a high-sensitivity troponin result. If you confine it to those patients under 30 where the masking occurred, you can see that in fact that result is consistent and in fact slightly more striking and statistically significant. This is a rise in, any rise and fall in troponin. And I'm sorry, I left out a slide that I should have shown you, which is the impact on non-coronary cardiovascular readmissions, for which there is absolutely no impact on that. So it does indicate that, in fact, the effect that we see on coronary events is real. So what we have been able to demonstrate in this study is, in fact, there is harm associated with high sensitivity troponin. And those of you in the audience who are clinicians will know that on August 17th, we were somewhat pressed to release the use of high sensitivity troponin onto the community, and now it's broadly available in all of our public hospitals. What we do know is, in fact, that there is an early hazard associated with the aggressive management of patients with low-level troponin elevations, and that probably crosses at a risk of mortality at 30 days of somewhere around 2%. So it raises the question of how, in our practice, right across the state and right across the world, in fact, practice might need to change. That, in fact, if we are able to identify patients at greater risk with a high-sensitivity troponin assay, maybe we need to think about different first-line therapies or first-line investigations to achieve this. So this is a randomized trial of 1,800 patients, for which we have just, that Flinders University has given us seed funding to seed the trial of randomizing patients who are who have low-level troponin elevations to either a strategy of CT versus invasive coronary angiography. If you like, uncoupling that decision between investigation and documentation of coronary artery disease with the desire to revascularize the patient when you find a lesion. This seed funding is also part of a submission to NHMRC for a $3 million randomised clinical trial to do this at scale, to do this right across 20 hospitals across Australia to embed this in practice. I would highlight that implementing high-sensitivity troponin, either T or I, is associated with the dramatic rise in identification of people with injury, but a very small rise in the identification of people with type 1 myocardial infarction. And type 1 myocardial infarction is that myocardial infarction that we have 99.9% of our evidence for. The evidence base for treating acute injury and for chronic injury, as well as type 2 myocardial infarction, those clinicians amongst us, those with supply-demand ischemia, is close to zero. But we do know that in the longer term, the risk of recurrent events in that group of patients, as you can see on the third panel, is actually very comparable, if not higher, than those with type 1 MI. So we are funded to look at the impact of unmasking. So as I mentioned to you on August the 17th this year, we felt compelled to roll out the use of high-sensitivity troponin, and we will actually evaluate the impact of that across the whole state in a simple before and after study. And as John has eloquently demonstrated to you, this is fraught with lots of bias because of the issues that we have with different practices and different ordering patterns. But we are able to do this across the state because we can use the data sets to follow patients long term. And I'll get into that in a little bit. But where we're moving to next is actually to try and enhance the decision making. So this is, if you like, the next step for how we might run research in practice, and that's the FOCUS project that John mentioned. So the idea is that with the evolution of the electronic medical record and other data sources, one can actually phenotype disease. So we can phenotype myocardial infarction and myocardial injury. We can phenotype low-risk patients. We can phenotype patients with heart failure and arrhythmias. And of course, we can phenotype patients with lots and lots of different other conditions based on the information that we collect both objectively in biochemistry, biomarkers, as well as radiology, but also by other characteristics through the electronic medical record. This project, RapidX-AI, is actually a project to phenotype myocardial infarction and myocardial injury, and in fact provide guidance for those decision support for those patients who we identify to be at relatively low risk or at high risk of type 1 MI, but then to facilitate research in patients who present with other forms of myocardial injury for which we need a better evidence base. So this is actually a funded study. We're going to study 9,600 patients, cluster randomized again. Again, John mentioned this idea to you. This won't be a stepped wedge design, but a cluster randomized design where we're going to take six metropolitan hospitals and 6 rural hospitals and cluster randomise them, so pick 3 in each of the rural and metropolitan areas and implement the decision support based on RapidX and see whether or not there's actually an improvement in care and outcome. This is a funded NHMRC partnership grant with all of the LHNs, the Commission for Innovation and Excellence, as well as SA Health. And we actually have a commitment of about $800,000 from Siemens in Germany to actually build this platform as well. So I'm hoping that we'll be able to demonstrate that improving that decision-making at the front line might improve care and outcome. But in fact, and so while that's already funded, it's the stepping stone to the next project we would have. So if you can actually phenotype disease through the electronic record and rapid access to biochemistry, hematology, and radiology, then you're in a position to potentially not only identify patients who are eligible for guideline-recommended therapies, but at the same time you are in a position to identify patients who come back to the health service with the event in question. And in that case, that's electronic adjudication. And so in building the RapidX platform, if you like, the manifestation of the focus phenotype idea, we can build a trial platform that identifies patients at the front end of the research question, facilitates the enrollment into studies, and then uses that same technology to identify recurrent admissions and recurrent presentations with the disease entities of interest. And this is what I'm calling the REMAP study, and you can see here that on the top line, under type 1 MI, there are the solid coloured boxes are guideline recommended therapies for type 1 myocardial infarction, whereas the boxes with arrows before them, bifurcating arrows before them, are obviously things that we need to conduct randomization in. In the blue box, in the second column, is actually early invasive management. And as a plug, we are currently funded by NHMRC to randomize patients with type 2 myocardial infarction and acute injury to early invasive management. And so if any of the clinicians in the room, if you have any, please reach out to us. We're keen to complete this study, which is running in 14 centres around Australia as well. But you can see that we can start filling in that evidence base, and a trial that's gone into the universities today for the current round of NHMRC is a $12 million study to study the impact of renin-angiotensin inhibitors as well as SGLT2 inhibitors in patients with either acute injury or chronic injury. So how is that possible? I'm sorry that the lines, because I've moved to a PowerPoint, don't quite make sense here. But the idea, and I'm hoping that you can still see the vague background of the previous slide, that we can actually interface with the electronic records to identify patients and make patient-specific recommendations. But those patients for which we don't have recommendations, we can actually use the platform to be able to identify who might be eligible for research and practice. We can use our electronic platforms to ensure that we have adherence or compliance to the protocol. So we can use our prescribing systems or our investigative systems to be able to identify whether or not the patient got the randomized therapies. And of course, as I mentioned earlier, it is important to be able to identify events at scale and the ability to link the data in real time for a patient who's represented with a potential outcome of interest and adjudicate that as quickly as possible is of critical importance in running these studies efficiently, because it means that you can build a virtual trial registry database, and that database is updated as quickly as possible, allowing such things as adaptive randomization, which improve trial efficiency. So I'm going to finish with this slide, and that is that we've been on a journey to try and progress this in the health system, and where, if you like, on this graph of trying to progressively build on our previous experience in running research and practice, to use the electronic systems to embed that research to not only build ongoing registries, but to then use those registries to embed randomization in practice, to do studies at scale to answer the questions that are actually important to us as clinicians. Andrew, I might stop there. Thanks.
Derek, fantastic. Thank you. Thanks very much. Great to see some new data. I hadn't seen it before. I know you'd mentioned it maybe to me earlier this week, but great stuff. I think we're very fortunate to see that. I love to see the sequential stuff that you're doing, learning, going forwards, and obviously the very elegant and rather great opportunity you've taken with the low, with the high sensitivity troponin T, looking at that low group there. You said we're forced to reveal these data on August 17.
Yes.
I think it's going to be very interesting. I wonder what you think will happen. There's, obviously lots of people wanted to see it, but maybe we got a counterintuitive result for some, maybe not for others, but it's a result for us. Where do we go?
Well, I think that what it highlights for us is that the assumption that we have as clinicians is that if you give me more information, I'll make a better decision, is not necessarily always a valid one. And that we do need to be measured and we do need to be robust in our approach to evaluating our decision making and the care we provide with systems that can actually do it at scale. And the real problem that I think we face in the acute care sector is that episodes of care are relatively short. For many of these patients, they were only in the emergency department for 4 hours. And so as a consequence of that, we are unable to be the William Osler measured clinician where you can take the time to absorb information and make a decision. We are going to need to embrace electronic systems, but not only does that, I'm hoping, improve our ability to make better decisions, but it opens up an opportunity for us to be much more objective and critical about the decisions we make and be evaluative about how we do that.
No, that's great, and I think your point that we sometimes get lost in doing more is well taken, and certainly from my area, intensive care, we're using smaller breath size. We're using the ventilator less than we did before. We're using other forms of that. We're giving less fluid. It's all about doing a little less. Sometimes we need to do a whole lot, but sometimes we need to do less. So that's also a great message. Has Slido helped us? No, it hasn't. It hasn't helped us, but I think that's okay, Derek. It was fabulous. It's going to take a lot of time for people to digest some of that. So thank you very much for helping us with our series. It's our last one of 5, but look forward to next year because I think we've got a lot more to talk about and a lot more to update as we go along and a lot more to learn. So thanks for joining with us, and any feedback very welcome as we progress into 221.
Thank you.
Thanks.